Good morning, everyone. Thank you for joining today's webinar, hosted by Health Choice Network and Alliance Chicago. The webinar will be starting shortly. The webinar will be starting shortly, but please join us for our word cloud. Type in 22333 in your phone text message box and put in COVID-19 heroes, and join us in with share one word that describes what you appreciate most about your health center population. During the live webinar, we'll be looking at everyone's responses. The webinar will be starting shortly. Our webinar will be starting shortly. Preparing communities for COVID-19. This is session number 6 on targeted telehealth. We are ever grateful for our community healthcare heroes. The webinar will be starting shortly. The webinar will be starting shortly, but please join us in our live polling word cloud. Take out your cell phone, text in the numbers 22333, and then put in the message line COVID-19 heroes, and you'll receive a response back. And today we're using our live polling function just for the word cloud, and we'll have one word cloud interactive session today. And what we'd like to know is share one word that best describes what you appreciate most about your health center population. We've got a few responses so far. Let's be resilient. The webinar will be starting shortly. The webinar will be starting shortly, but we wanted to share with you some of the healthcare heroes that are helping fight COVID-19 across the country. You'll see in front of you pictures of our community health center partners working every day. Thank you, thank you, thank you. The webinar will be starting shortly. The webinar will be starting in just a moment. Preparing communities for COVID-19, session number 6 on targeted healthcare, targeted telehealth, sponsored by Alliance Chicago and Health Choice Network. We'll be starting in just one moment. As we start today's webinar, we'd like you to take out your phone and join us in a live polling. In the to line, put in 22333, and in the message line, put in COVID-19 heroes. You'll get a response back, and then you'll be able to participate in our live functioning with the word cloud. And today's word cloud question is, share one word that describes what you appreciate most about your health center population. We have some great responses coming in, and this will be a live interactive word cloud throughout today's webinar, which we're going to be starting in 1 minute. So good morning, everyone. My name is Tim Long, and today we have our 6th session on preparing communities for COVID-19. We'll be talking today on targeted telehealth. This webinar series is brought to you by Alliance Chicago and Health Choice Network and all of the many health centers that have joined together as healthcare heroes to work on COVID-19. As we start today's session, we'll have some live interactive polling functions and also our word cloud. Today, we'd like to hear from you as we start today's webinar. So take out your cell phone and type in 22333 in the to line in your text message and put in COVID-19 heroes. And then you can participate in our live word cloud. And today's webinar question is, share one word that describes what you appreciate most about your health center population. Throughout today's webinar, you can type this in, and at the end of today's webinar, we'll again look at our word cloud of one word that we appreciate the most about our healthcare population. So again, welcome everyone. This is Health Choice Network and Alliance Chicago's webinar series on COVID-19, preparing our communities. For today's session, session number 6, we're going to talk about targeted telehealth. But before that, we will hear from Dr. Fred Rockman and Alex Remillo, the CEO of both Alliance Chicago and Health Choice Network, respectively. And then we'll hear directly from our health centers. Today, under targeted telehealth, we'll hear from a number of health centers, their experience with COVID-19, their stories about telehealth, and hopefully we'll be able to learn a little bit from each one of them. And then we'll hear from our partners on the national level, from the National Association of Community Health Centers. Throughout today's webinar, we will have some polling functions. Today, we'll be using that through the GoToWebinar application. So first, as we start today's webinar, let's hear from our colleague at Alliance Chicago. And Dr. Fred Rockman is the CEO of Alliance Chicago. So good morning, Fred. Are you with us today?
Yeah, good morning, Tim. Can you hear me?
Yes, perfectly.
Great. Well, you all, it's hard to believe it's been 6 weeks that we've been gathering to digest the pandemic on these webinars and share observations, challenges, responses, and learn together. While we all know it's been painful, I'm sure we all agree that we seem to have advanced at light speed on approaches that we've been discussing for years, especially in terms of alternative approaches to engaging patients and delivering care. There's been quite an emphasis on virtual care and telemedicine, and we're going to continue that on today's webinar. It's clear that as we see people beginning to talk about resuming activities and slowly reversing the extreme social distancing measures, we're talking about a return to a new normal, not the old normal. And those of you who have paid attention to CMS and Seema Verma's remarks recognize that virtual care and telemedicine will be a permanent part of that new normal. At the networks, and hopefully all of you, we're turning our attention to how to leverage our learning to build a more sophisticated, enduring infrastructure that will enable us to be leaders in that future new normal. I hope you all have applied for the FCC funding we talked about last week. Although late, we're still at the ready to assist any of you who have not, and hopefully you're all looking at other opportunities that are beginning to emerge. We at the networks are also working together to help bring clinicians and other health centers leaders together to plan thoughtfully. So as we listen to today's panelists, please have a long-term perspective in your minds and engage with us on that. So back to you, Alex and Tim.
Great, thank you very much, Fred. Appreciate those words. And next we're going to hear from the CEO of Health Choice Network, Alex Remillo. Alex, are you with us today?
Good morning, Dr. Long. Can you hear me?
Yes, perfectly.
Perfect. Well, welcome everyone. Once again, as Fred mentioned, we want to thank all the healthcare heroes. I've had the pleasure for the last several weeks working with the executive teams of our member health centers and looking at data and looking at the pivot the health centers have made, not only to deal with this COVID-19 crisis, but just to serve their communities as you've always done. Always been a fan, you've always been my heroes, but to watch you be first in your communities, to do so many things and to step up to the plate and do the work that is required of you, not the work that's being funded, not the supply that you need, not the staffing that you need, is truly heroic, and I appreciate those efforts. As Fred mentioned, here at the network, in the partnership with Alliance Chicago, we're working on several things. Our board of directors were actually visionary. About a year ago, we started talking about what the new healthcare model would look like, thanks to Dr. Rockman's guidance and what our patients are going to need to be able to compete and provide delivery services that are quality-based in our communities, specifically with the new generation and things that are changing in healthcare. I can tell you that as you look at the stock market and the fiscal impact of this, you can see that Amazon has not weathered. Their stock actually continues to rise, along with other organizations that are very servient to their customers, whether delivering at home food or delivering products and needs. And so as we look at this, this pandemic and the opportunity that telehealth has provided us, we're operating under a lot of waivers that have lifted guidance and requirements for HIPAA, billing, our clinic rate, our wraparound rate, et cetera. And those will not stay. So it's going to be very important that whatever we build for the new normal, as Dr. Rockman mentioned, is long-standing, and that it could weather the storm and be able to provide the quality care and serve our communities as done before. Stephanie, can you forward the slide? So one of the things that I wanted to do, because I'm a graphic person, we'll just highlight some of the things that we're looking at for the last year or so as we work together, as our networks work together. It's not just the ability to launch a telehealth platform. Many folks are focusing their efforts on the FCC application because it's required to look at applications and technology. I guarantee you the technology that you're using today will be very different in the next 6 months, because every technology company from Microsoft to Citrix to others are looking at what a true telehealth platform would be that requires almost no technical support for the patient or the clinician. And one of the items that our board and our providers have pushed us to is telehealth, and the virtual health care is not just audio and video calls. It's also in-home care. I've said this before in some of these webinars, my healthy children will never sit in a waiting room waiting for a pediatric provider ever again. And we're seeing a lot of that. A lot of my daughters, by the way, one's in college and one's 10 years old, and they're both on their phones all the time. So they realize that what they wanted, which was immediate access to their providers when they're not feeling well, is going to become a big reality for us. So as you pivot and you look at your workflows, I think it's important not to focus your long-term play on what's happening today, but also how well health centers and our provider care delivery will change in the next years. Because our new normal may require a lot of drive-ups, in-home care, the ability to educate, the ability to have specialty care at our fingertips. So I'm excited that our board of directors at the Alliance Chicago and the Health Choice Network had this vision a year ago, and that we're partnering up, not for the pandemic, but to make sure that we're the top level, the largest primary care health system, and the most successful in the country. So with that, I'll turn it over back to Dr. Long. And thank you for all the Health Center panelists. You guys are truly amazing to share your best practices. It's great to see so many familiar faces on panelists, and thank you.
Thank you, Alex. Those are great words, and definitely virtual healthcare and connecting with patients is here to stay. And as we move into this new normal, this new telehealth virtual world, hopefully all of our health centers will be with us. And today we're going to hear from a number of them. So as we advance the slide, let's take one moment before we start to have one polling question. You don't have to take out your phone here. We're going to do this right on the GoToWebinar application. And our polling question is, what healthcare or telehealth platform is your health center currently using? And on the next slide, we'll be able to get the answers. So what telehealth platform is your health center currently using? And there might be more than one. So if you are using more than one telehealth platform, check all that apply. We're going to give this a couple of moments for you to all join in. Our first quick poll question, just click which telehealth platform or platforms that your health center is currently using. And let's give that about 2 or 3 more seconds, Stephanie, and then we'll close the poll. And why don't we go ahead and close that poll? And it looks like Doxy.me has about 49% users among health centers, Zoom a 44%, Doximity a 9%, and then other is 25%. Thank you for participating in our first quick poll of the day. And now let's get to the real interest that we're here for today on today's webinar, hearing from our health centers. The first health center we'll hear from is our partners at Community Health Centers of Pinellas. So, Dr. Doherty, are you with us?
Yes, I'm here.
Great.
Thank you, Dr. Long and Dr. Rockman. Thank you for letting me join this webinar and letting me share our experience at Community Health Centers of Pinellas. Just a little bit about us briefly. We have 13 locations throughout Pinellas County in southern Florida, and out of those we have 2 dental locations. All of our locations have various health services for primary and behavioral health needs. So to get into it, I think no matter what kind of healthcare work we are in, we were all literally impacted overnight with the challenges of practicing during COVID-19 pandemic. We were all met with challenges to protect our staff, preserve PPE, and promote social distancing in waiting areas and reducing patient flow into buildings. We also had to implement telehealth technologies basically and frameworks overnight. In the dental field, we were one of the most at-risk healthcare provider types due to our need to be close to the oral cavity to do our work and the aerosolized respiratory droplets that we create doing our work. So depending on what state you're in, we had to meet state and local government guidelines to stop doing elective procedures, which initially was a definition left open for practitioners' own interpretation. Eventually, though, national, state, and local organizations came together to make recommendations on what dentists can do, and it turns out that this is basically limited to emergency procedures, which are generally tooth extractions. So overnight, the dental profession basically lost most of its services it provides. They were wiped out with good reason due to COVID-19. Unfortunately, for our situation here at Community Health Centers of Pinellas, we saw our daily dental visits drop by 75 to 80% almost overnight. So in response, we had to make the tough decision to close one of our dental clinics temporarily and put all of its staff on temporary furlough, leaving us only with one dental clinic in the county. We were left with this challenge of how do we help our profession survive and maintain access to our patients while also trying to keep our remaining staff busy and meet the requirements to do our humanitarian duty to prevent the spread of the pandemic. So in comes teledentistry. It kind of seemed invaluable to me at first. How can a dentist do anything virtually, right? But I was lucky enough to have some senior advisors who encouraged me to give it a try. So we did, and our team went all into teledentistry. And we figured if we were going to do it, we were going to do it to the best of our ability. So here's what we did. We first came up with a process for synchronous telehealth and asynchronous telehealth based on guidelines provided to us by the American Dental Association. For synchronous telehealth, that is a live option. So that's basically a video feed that's going on between you and your dentist at the same time. On the screen, you can see a picture of a dentist doing oral hygiene instruction with a pediatric patient, which is a great way to use synchronous telehealth. We've tried almost every video platform there is. We've done FaceTime, Zoom, and Doxy, and as all of you indicated, Doxy seems to be the most user-friendly. But as with most organizations, we are looking into be a more permanent solution because as Dr. Rockman and Dr. Long said, telehealth is really here to stay. It's a long-term thing. For asynchronous telehealth, that's a store and forward option. So that means you have a dental provider in a remote location maybe, and they're taking digital pictures or x-rays, and they're sending them to the dentist to interpret later on. So we were fortunate enough already to be in the possession of a folding portable dental chair, a no-bad portable x-ray unit, and an intraoral camera. And we implemented this with a hygienist in a more remote part of our county that doesn't have much access to dental care. And we took one room in an existing medical clinic to set up our shops, basically. We're now able to take emergency dental patients there. The hygienist does diagnostic imaging. She sends them to the dentist securely through our electronic health records, and the dentist makes a call to the patient within 24 hours to discuss the problem, make a diagnosis, and set up treatment in our clinic that is open. The great thing about this is the dentist can send any prescriptions electronically that the patient may need to the pharmacy that's by them. We can prevent unnecessary trips to a clinic that's far away if perhaps the patient needs a referral to a specialist. And we can also help them arrange transportation via Uber Health if needed. Overall, we've had wonderful success with both models and are better able to triage and screen our dental patients before they walk into our clinics and put themselves at unnecessary risk for exposure to COVID-19 and also protect our staff. Next slide, please. So here are some tips that we've learned along the way with the teledentistry process. It's been a bit of a bumpy road, but we're learning as we go, and we think we're doing a pretty good job. Every day is getting better and better. As far as scheduling goes, you want to make sure you have everybody who touches the dental schedule involved in this and know what's going on. Make sure you talk to your front office teams, your dental assistants, and your phone or call center folks, and that make sure they know what to expect, what to be able to tell those people on the phone when they say they're getting a teledentistry visit. Do a practice trial run teledentistry visit so they can see what it is and what it's like and be able to explain it to patients better. We do a 15-minute scheduling template for teledentistry, and we allow 30 minutes for new patients and 15 minutes for existing patients. The reason for this is to allow more time for registration of new patients. They have a medical history that they can input. We use a system called GetWell. We had previously used that in our centers, which is an iPad registration system. And initially for new patients, we were having them drive up to the tent and stay in their cars. We would have somebody fully dressed in PPE come out to their car, bring them the tablet, and they would do their full registration and medical history on the GetWell tablet in the parking lot, and then the telehealth visit would take place from there. However, now our wonderful IT department has found a way to have GetWell registration packet emailed to the patients, so now they can do those registrations virtually from home, and we can get the call done through Doxy as well. But that is a major consideration. You want to think of new patients versus existing patients. And also a great thing when scheduling to talk to your schedulers about is to screen patients for COVID-19 questions. You know, ask them if they've had a test, if they've been exposed, if they've been traveling, or any fever recently. And that can tell us better, hey, if we need to schedule them in the center for something, maybe there's some documentation we need to get to say that they had a negative test. It just prevents unnecessary trips and unnecessary headaches for the patient. The second point, another thing that we've found very helpful, is to designate one of your dental employees as a telehealth liaison. This is a great position for a hygienist who's not able to do cleanings right now, or a dental assistant who's maybe not as busy as they typically work. They can vet and confirm the telehealth schedule. They can call the patient if they're having technical challenge and help them work on getting on the video call, or maybe get their microphone set up. Patients aren't used to doing this, so they do sometimes need a little coaching. They can call the patient and remind them if they're late for their telehealth patient or their telehealth appointment. We found that that's a very important thing to do, to call the patient right at the time of their appointment and remind them to click on. So it's been a very useful position to have, and we see a place for it lasting in the future. All the dentist has to do really is direct patient care. It's wonderful. They can look at the patient through video chat. They can do verbal consents for the telehealth. That's what we're doing right now. They do the electronic health record documentations. And what I found is allows us to spend more time with our patients than maybe we would in a typical setting. We can have a better, longer, deeper conversation to get to the root of what the problem is. The fourth thing there, this is kind of an obvious thing, but you need IT. Let IT know what you're doing, and they can offer technical support, help you with your platform selection and hardware setup, especially if you're using a Nomad, digital X-ray, portable X-ray, or digital camera. You will need IT to help. Sometimes it's as simple as just turning up the volume on your computer, but they might need to be there to tell you that. The fourth thing is communications and advertising. We are also blessed with a wonderful team that does social media posts for us and lets our patients know what we have to offer and what's going on. And that's so important. You'll see an advertisement that's been posted on doors, blasted through emails, text, social media, and everything. And that's been a great help to us, our success. Providers from other departments. Let your providers in other departments, pediatricians, family medicine doctors, let them know what's going on, and they can send you referrals to your dental department. And then finally, the finance team can offer you coding and billing support. It's a new thing. There are codes out there for teledentistry, and they're all some common ones are listed on this screen here that you could use. But there's some confusion about it. There's a lot of websites out there and documents by the ADA that can let you know and offer support on what codes to use when you bill. But that's just a kind of starter guide, and always go to your finance department to have them let you know what will work the best. Next slide, please. So it's been a little bit of a trial and error process, but I'd like to echo again the comments earlier that this is a long-term thing. Teledentistry and telehealth is here to stay. It's really starting to take our place in our profession, and we've had great feedback thus far from our patients. It can be successful in so many future areas of access opportunities, school health, remote sites, and mobile health. If you have a dental bus, medical dental integration, setting up right in your pediatrician's office, reaching out to know patients via telehealth, and work from home opportunities for your dentist or other providers. Next slide. With all that information being said, I want to say thank you to HCN for inviting us all to be a part of these webinars. We have an unprecedented situation in front of us, and now more than ever, we need to come together to learn from each other and share ideas, our successes, and our failures. So thank you again for having me, and my contact information is on the slide. If anyone needs to reach out, I would be happy to share any ideas that I have. So thank you.
Great, thank you so much, Dr. Doherty, and thank you for everything that you guys are doing at Community Health Centers of Pinellas. Phenomenal work and a great presentation. We did get a number of questions in the chat, so keep sending those questions. We will be sending the questions to the speakers or the panelists. We may or may not have enough time during the live broadcast to answer those questions, but we will get them answered, if not during the broadcast, then after. And also, on your right-hand panel of the GoToWebinar, you'll see some handouts. There's a handout section. We have both a handout from one of the health centers, but then also we have today's webinar slide deck in a PDF version that you can print out. It's 76 slides, so you might want to save it first and then email it out to your colleagues. So as we go to our next health center, I want to welcome our colleagues at Care Resource. And Dr. Santiago is going to talk with us and his colleague about HIV and PrEP telehealth programs. So Dr. Santiago, are you with us today?
Yes, I'm here.
Great.
Can you hear me? Yeah, okay, great. Yes, hi everybody. Thank you, Tim, and thank you HCN and Alliance Chicago for inviting us to talk to you. We were saddened because earlier in April, we were going to do an HIV and PrEP update for ending the epidemic. And well, fortunately, we were able to help now at the end of April with this HIV and PrEP telehealth webinar. So thank you for doing that. We have Dr. Zayas on the call too. She's at the office. I'm at home, so she'll be chiming in as necessary. We started actually. This is basically what I'm going to be talking about: background, patient engagement tools, and workflow. Some of which was discussed in the previous presentation. Next slide. All right, so we started with telemedicine or telehealth early in 2019 with our behavioral health department. We received the CDC grant to help our Black MSM youth, both with their HIV care and also with HIV prevention due to high-risk behaviors, and it was very successful. So in the summer of 2019, we began offering telemedicine for the incarcerated transgender population in Florida, offering hormone therapy for them. And at the same time, we began offering telemedicine for our PrEP patients because we found that although we had a pretty good retention and care of about 80 to 85%, it still wasn't high enough, to satisfy what we thought was necessary to prevent HIV. So we started offering to our PrEP patients with only a few providers doing it at first to kind of get our feet wet. And it was very well received, as other member centers have said. It really does help the patients access medical care in a much easier fashion. So fast forward to March of 2020, and we expanded it to basically all of our patients, but especially those with HIV, and also for post-exposure prophylaxis, being that we really slimmed down operations in order to flatten the curve. So although we had one provider at each location seeing patients for urgent needs, we tried to keep as many patients out as possible, as well as keep staff out. By now, at the end of April, we recently looked at our productivity, and we found that we're almost at exactly the same level we were in early March, and we anticipate soon we will be surpassing what our productivity was ever before. So definitely, this is a silver lining to what's happened to us, and hopefully will help us in the future. Next slide. So, as mentioned before, there are a lot of things that we need to do to make sure we get this right. And it is a little bit of a work in progress, as I'm sure all of you feel the same way. We had to educate our call center staff to make sure that we contacted all the patients that were scheduled for appointments in order to try to switch as many of them as possible to telehealth. Patients were very receptive to this, as many patients, especially those with the HIV, did not want to come in and risk harming themselves, but also patients with diabetes and hypertension were aware of the dangers of COVID-19. We were able to reassign staff, so we fortunately have not needed to furlough any staff. We've tried to be as creative as possible to utilize existing staff in order to meet the services that we need. So, for example, we only have one dentist at each of our dental clinics seeing patients for emergency care, but otherwise we have dentists, hygienists, and dental staff helping with calling, rescheduling, reports, and other duties as needed. If the dentist doesn't have any emergency case to take care of, they're also helping at our tents. We have 2 tents, and they're helping with doing testing as well. So that's a very useful way to use staff and be able to keep from furloughing any staff. We have been able to be very aggressive at creating reports, which is standard of care actually, but being more diligent about following up with patients that haven't been seen in more than 6 months to make sure that they know that that they can be seen via telemedicine. Patients that we had to reschedule due to COVID in March and April are being called to be rescheduled. You know, one of the challenges that I'm sure some of you have faced is that patients oftentimes don't answer a phone when they don't recognize the number. And fortunately, you know, we've become creative, and you know, we're leaving a message letting them know we'll be calling back in 5 minutes. And oftentimes that has some good results in terms of patient then answering the phone and us being able to let them know about the services or set them up. We have a very strong marketing department, and in fact, we have gone crazy promoting our telemedicine, telehealth abilities. We have communication to the patients via the portal, mass text messaging. We have very strong presence on Facebook, Twitter, Instagram, etc., YouTube, where we are able to boost our media advertisements. Next page. And we have paid web banner and print advertisements in local media, a number of local media, and we are able to include these as well in internal and external email blasts. We have continuous TV commercials on Atlantic Broadband and other cable services. We have targeted public service announcements on iHeartRadio. And we created PrEP and non-occupational post-exposure hotlines, which you can see here, in order to help our patients. As well as was mentioned in the previous presentation, we offer Uber Health in order to get our patients in for HIV care or PrEP or post-exposure prophylaxis. We have also been able to offer in-home testing to our patients, in-home HIV testing, I should clarify, for our patients in order to be able to determine whether they need to be offered test and treat or be set up with PrEP services or post-exposure prophylactic services. So that's something that is very useful. If you need any help for those centers that provide HIV and PrEP services. If you need help with how to set those up with your county health departments, please send me an email, and we'll be happy to assist you in setting that up. Now, with regards to our SOP, and I don't want to go too much into the mud here because I know it's been discussed in the previous webinars. So basically, the great thing, as was mentioned earlier, is that we are now able to provide care to new patients. We were never able to do that before via telehealth. So aside from our work with the incarcerated population. So now we'll be able to provide new patient care to most patients. We do pre-registration, we do verbal consent, of course. We constantly are revising our telehealth SOPs. So for example, we started off with Zoom. We found that a lot of patients were having trouble with that. They're not exactly tech savvy, or they don't have access to a web browser or smartphone. So then we started using Doximity Video. We're going to be moving forward with a next-gen incorporated virtual visit platform called Otto. And so that hopefully is going to be the best of all worlds, but I foresee that we still will need to use some of the other means. So what this means is we'll just continually need to revise our SOPs to make sure that we get it right. We make sure to do appointment reminder calls by the front desk in order to make sure we know which ones are appropriate to switch to telehealth. And you can see there the different codes so that we know whether the patient or the provider is in or out, or both are out. This helps in terms of the flow of the patient care to make sure that the staff in-house knows exactly what needs to happen for the patient visit, and also to make the procedure go more smoothly for the providers that are at home, because it's really difficult when the provider has to kind of negotiate with the patient how to get them set up with the video platform in addition to the visit. So it's very helpful to have the staff do that. We also offer COVID testing via telehealth. So for example, if a patient calls in and says that they want to be tested for COVID-19, we have a provider actually do a telehealth visit with the patient. They're registered, of course, beforehand, and then the order is put in by the provider, and the person then goes to one of our testing sites in order to get the test done, and then the results are followed up with another telehealth visit. Oftentimes, we're finding that these patients didn't have any primary care providers, which is why they're trying to get tested through us, and are very happy to continue their medical care with us in the future. So you can see here a little bit more of the details with exactly how we do our standard telehealth procedures. You know, what I want to say here is that, of course, what makes it special for HIV and PrEP is that we continue to provide test and treat and rapid access services in both counties, Broward and Miami-Dade County, although we are not getting any funding from the Department of Health for test and treat at this point. We feel that it's extremely important. So they have been referring patients to us. As I mentioned, we are able to offer the home testing. The patient gets the test. If they're positive, we see the patient via telemedicine, and we send a prescription to our in-house Walgreens. The patient is then goes to the Walgreens, is able to get registered if they need a patient assistance program or pick up their medication. They get that, and then the provider will do a telehealth visit and put in the lab orders, because of course we need to do some labs. Mostly the issue is that for both HIV and for PrEP patients is to make sure that we do hepatitis B surface antibody, because we don't want to have a flare for those patients that may have co-infection with hepatitis B. Otherwise, we know that most of the treatments for HIV and PrEP are extremely safe nowadays. Cheryl, do you want to say anything else about this particular slide? We have constant help from our finance department with regards to billing and coding to make sure that the providers are getting it right, because that was one of the challenges that we had in order to set up NextGen to get the right codes in, or make sure the providers were aware of which were the correct codes. You can see I mentioned in the slide how to code for PrEP. We use the ICD-10 D20.2, which is contact with suspected exposure to infections with predominantly sexual motor transmission. We have not had any problems whatsoever with getting reimbursed for visits with that diagnostic code. Cheryl, I don't know if you're there, if you're able to make any other comments, or you feel like you need to make any other comments.
I think you're doing a great job. I think the point is that we really are minimizing the amount of time that the patient comes into the office. Even though they do have to come in for labs, it is a quick in and out, and there's no visit by the provider in-house.
Okay, great. Yeah, although, of course, we are available, and Cheryl, for example, is in the office today available, and she has about 5 patients that she's seeing. Maybe, I'm not sure if there's another webinar that's going to include MAT, but Cheryl is our czar for MAT, just in case you need anybody. I just want to finish by saying that this is really going to be a win-win for patients and for the health center. So for the patients, it increases retention and adherence. It's going to improve outcomes. And since patients are being more well retained, it's also going to help the health center with our patient visits and our 340B revenue, because we often had patients that were lost to care due to inability to access services. So thank you, everybody.
Great, thank you very much, Dr. Santiago and team. We really appreciate all the work that you, your care team, and Care Resource is doing for Southeast Florida. So thank you very much. And we probably, Steve and I, will be calling you about the MAT webinar in the future. So I heard that. So as we turn to our next item is a polling question. So you don't have to take out your phone here. We'll do this right on the GoToWebinar software. So our second polling question is, which services are being provided using telehealth at your health center? Chronic disease management, prenatal, pediatric, behavioral health, dental. As we switch over to the next slide, we will open the poll right on the GoToWebinar, and you can choose more than one if more than one apply. So what services are being provided using telehealth at your health center? And there might be even more than these 5. We were limited to 5 choices. If you're providing all 5, then check all 5. So let's give it just a couple of moments for everyone to put in their answers for what services are being provided using telehealth at your health center. So Stephanie, why don't we cut over and look at the results of our second quick poll question. And it looks like a lot of people are doing behavioral health, which is fantastic. We have a lot more experience, longer period of time with behavioral health. Chronic disease management is close second. And then we also have significant amounts of pediatric, prenatal, and dental. So thank you for that poll question, number 2. Next, let's hear from another one of our health center partners. And here we have Health First Bluegrass and Tara. Are you with us, Tara?
Can you hear me okay?
Yes, we can hear you perfectly, Tara. So thank you.
All right, great. And thank you for the opportunity to present this afternoon. I think I just first want to start by saying from here in Kentucky, we're sending all of our best energy to everybody's way that might be suffering from this a little bit harder than we are. We've been pretty okay in Lexington so far, but definitely sending best thoughts and wishes to everybody because I know it's a struggle everywhere. So if you look at the first slide, I just wanted to give you a little bit of a just size and scope of what our behavioral health team is. We had a little bit of telehealth experience just with one provider to one of our healthcare for the homeless sites. We piloted that a couple of years ago, and based on some staffing things, we really didn't need it and just went ahead and did true face-to-face service to that clinic. But outside of that, I had a little experience in a previous position I held with telehealth, but for the most part, all of us were newbies to it. So it was quite the shift to swing basically what felt like overnight. I wanted to give you some size and scope. We have 15 clinics in the Lexington area here in central Kentucky. 9 of those are school-based health clinics. Each have behavioral health staff. So when the schools closed, it really put a big press on shifting where patients could pick up medications, where patients could contact for questions that they had. So we turned one school into a well school site where patients who were not experiencing any kind of COVID-related symptoms could come, and one school into a sick site testing site. We did not continue behavioral health services at those sites, but wanted to support them in case behavioral health needs came up. But it left me with a ton of behavioral health staff floating around in the universe trying to figure out what to do. So if you go to the next slide, I'll tell you a little bit about how we shifted our services. Our first phase was really to identify, after the first positive test started coming into Lexington, was to identify who were our most unique role players within our team. So, for instance, we have 2 adult psychiatric prescribers, and the thought of one of those people were to get sick or both get sick, and then you eliminate one of our main goals, which was to sustain medication. Our primary goal was, once we started planning for this, was sustain meds for our patients, be available to assess any kind of imminent risk situations that came in, any kind of suicidality, homicidality, those things that we normally do, and prioritize our patients who were already established and we knew were experiencing really high risk or had an intensive safety plan in place. So we wanted to make sure that we would keep the staff in case something terrible were to happen, that a lot of our staff were to become symptomatic. So we moved those people out immediately. Also moved, had a couple of staff who were pregnant, a few more high-risk situations. We moved those out, and then took about another week to transition everybody to telehealth. So it was a big push really fast. We have left at this point 1 behavioral health consultant. So our model is to have, we have therapists and psychiatric prescribers in our school-based clinics. We have embedded onto our primary care teams behavioral health consultants and community health workers who do on-demand working with the primary care docs. As somebody comes in and identifies a problem, they are there in that same visit with the doctor, seeing that patient and following up with them. And then we have a traditional service line so that when it's more outside of the scope of what that on-demand service is, they're able to kick that to a more ongoing therapist who has more time to spend with them. So we moved them all to telehealth, minus 1 behavioral health consultant who stayed in the clinic to support the medical teams who were still working. And we shifted that behavioral health consultant position every 3 weeks. So this is week 1 for the one of our BHCs who's been working at home for the last 3 weeks. After this week and 2 more, another one will come in and replace her. The ones who are out and off-site, they are working telehealth. And then we are currently only seeing patients in. Patients can come in to get lab work. They're not having visits when they come in for lab work. They're waiting in the parking lot until the lab calls and tells them to come in. And we are still seeing patients in clinic for injections. So we have a pretty significant population of patients who receive a long-lasting antipsychotic injections. So we're having them come in for those injections, but not for their visits. Next slide, please. Our big goals, like I said, prioritize risk, sustain medications, keep staff available, making sure that and that, as everybody knows, it went so fast that it went from planning for this person will work this week and not this week to everybody just needs to be out. We don't have to be in the clinic, so we don't need to be there and don't need to have patients coming in to expose them. And then what weighed probably heaviest on me was keep staff working when all those schools closed and when you have so many people working from home, making sure that we can do our best to not have to go toward any kind of plan for layoffs. And we've been pretty successful that way. What we did with our school-based therapists whose work world pretty much was destroyed for those first couple of weeks is we turned them on to setting up telehealth opportunities for all of our behavioral health patients. So they take care of their caseloads. And then they also started calling other patients and setting them up. In the beginning, we went with Zoom. Zoom was very helpful because for our school-based clinics, which, like I said, we have quite a few of them, that's what they did their non-traditional work. The Fayette County Public School System here had already provided much of our lower-income patients, which are in the schools where we serve, gave them Chromebooks, which had Zoom installed on them. So we asked the school if we could have permission to use their Zoom product that they already had on the school laptops, and they were like, yes, please see those kids. And so that went great because the kids were so familiar with it. For our other patients, our primary care patients, they're now using DoxyMe. So we're transitioning a little to DoxyMe, but allowing providers to have the option to do both of those things. And it's just really helped be able to spread the love around. Our team's been great about understanding, I'm not billing at the same rate as I originally would have been. I'm not seeing as many patients. So yeah, I can spend, a couple hours a day calling patients and talking them through what it means to download the Zoom app or what Doxy's going to look like. So telehealth, we also designed some quick text within the EMR to help hit all of the verbiage for telehealth consent. And like everybody knows, things have been a little bit lenient during these times, and so we're now working on our more formal. We had a pretty formal telehealth consent from when we tried it once before, but we didn't have the ability to do that electronically. So we've now built into a platform called DocuSign the ability to send consents to patients and let them sign those electronically and get those back in. Getting them back into our system has been a little bit of a challenge, but we are right where I think we need to be with that to make it something that will sustain and let us be able to do telehealth into the future, even when we don't have to. But the quick text was helpful for getting everybody's verbiage right there into their node and to know which pieces they need to talk about with the patient and what things they needed to cover. We're also doing curbside vitals for our psychiatric prescribers. We've got everything but weight. So the patient pulls up out front and one of the medical team staff go out and get blood pressures and pulse, those kind of things. We are asking patients to weigh themselves at home when that is required. For our MAT patients, we really dropped, my background is very heavy in addiction. I used to operate at Kentucky's oldest methadone clinic, so I am deep in the mindset of DEA and all the regulations and all the things that come, and it's really been a mind blower for me that during this time, the encouragement is don't do all the things that we've always required you to do. And it's been really freeing. So we've dropped the having patients come in and do urine drug screens. We're talking with them regularly. We actually did our first in-home induction a couple of weeks ago that went really smooth. We were very pleased with it. And we're just upping the amount of time that we're having our behavioral health consultants check in with those patients. We have community health workers here. Community health workers are bachelor's level patients or bachelor's level staff that we've hired to work with patients on more resource type of linkage. They have been critical and crucial for all of our work during COVID-19. They have been working call lists and focusing on high-risk patients. So the first thing we called was our 60 and over patients with a chronic condition, which was like 6,500 patients or something like that. They split those up, started calling, informing them about pharmacy changes and being able to extend their medication refills. They're talking to them about testing sites that are popping up, just checking in with people. And what they found were a lot of really lonely patients who were isolated and quite afraid. We found a lot of patients who were afraid to come in to get their medication. So we set up a delivery system to be able to help them out and utilize some of our staff who weren't as productive as they normally would have been in their normal clinic settings. But they found that to be very gratifying, calling those patients. We called we're working through a list of our African-American patients focusing on 65 and older females right now, and finding just the same kind of conversations around, thank you for checking in on me, thank you for calling me, people are lonely, and often finding people who need to go be tested and we're staying at home and we're too nervous to try to do it. And so making those recommendations and screening on every call for COVID-19. And then the last thing I'll talk about is my biggest fear in this whole thing is I have blood, sweat, and tear breathed into our integrated health program for the last 2.5 years. And my fear of having however many months this is going to extend for a period where the behavioral health team is out of sight of the behavioral health providers who are on site or those who are working from telehealth from home is that we'll lose traction in the amazing progress we've made with integrated health. And so we want to make sure that they know we're still available for on-demand work. We use Skype a lot. The docs Skype us when they have a patient that's either on the phone or on video visit or in the clinic that they need service with. But we also developed a team behavioral health desktop, which has been helpful. And so my message, we do webinars Monday, Wednesday, Friday. The executive team at our center does a webinar just talking our staff through what's going on. And every single time my message is, if you have a behavioral health concern in front of you and you don't know what to do, put it on that desktop, and I have a person assigned to the desktop who's combing that and offering video or telephone assessment and consult immediately when those pop up. And so that's being utilized pretty regularly, and we feel like we're staying pretty connected as much as we can with those medical teams. That's pretty much a summary of where we're at right now. We're happy with it. I certainly have staff that I think will want to continue being telehealth providers when it's over, and I certainly have patients that I think like this experience just as much as they do coming into the clinic. So we feel pretty good about things. The rest of everybody like me are going to be glad when it's over and we can get back to eating lunch together. But we're doing okay here, and hope the best for everybody else out there. Thank you.
So thank you so much, Tara. That was great information. We really appreciate this story that you tell from Health First Bluegrass, and we miss everybody there. So say hello to your entire team there, and thank you once again for telling your story on today's webinar. So as we turn to our next community health center, we're going to hear from our colleague, Denise, at Archer Family Health Care. Denise, are you with us?
I am. Can you hear me?
Yes, perfectly. Welcome.
Okay, great. Okay, well, thank you for having me. A little bit about our clinic first, if you want to go to the next slide. So my name is Denise Shentrup, and I am the clinical director of Archer Family Health Care. This clinic is located in Archer, Florida, which is about 15 miles from Gainesville, Florida, where University of Florida is. We are owned and operated by the College of Nursing, and all of our providers are nurse practitioners, so we call ourselves a nurse-led primary care practice. So prior to this pandemic, we are a federally designated rural health clinic. So as a rural health clinic, we were not able to provide telemedicine services. So our billing and coding guidelines are governed by federal guidelines. So with that, we were not able to perform these services. So all of this has been really foreign to us. Next slide. So with the CARES Act, even though we are in these negative times, we always want to think about all the positives that are happening with this. And one of the things was that one of the bigger things that happened, number one, is that we are able to do telehealth. But another thing that happened is that we as nurse practitioners are now able to order home health services for Medicare patients. So this also has been a big deal, because if we are not able to reach the patients by physical visits, this gives us the ability to order home health services to get someone out to the house to do an assessment and manage the patient, or help us manage the patient remotely. Next slide. Next slide. Okay, so with the CARES Act and the ability for us to do telemedicine, we really had to start from scratch, because again, we, as a rural health clinic, were not able to do telemedicine. So what we have done is we created some criteria that we thought might work for patients who are coming in for certain things, and what visits were conducive to telehealth. So we've had our front office staff, we've only been doing it for about 2 or 3 weeks now, but what we have been doing is having our front office staff identify patients either when they call, or patients on the schedule that a telehealth visit might occur. In our practice, we do have an integrated model of primary care and behavioral health. So the behavioral health piece is typically easier to do telehealth. So with that being said, we wanted to identify where on the primary care side that we could do telehealth. So we've adopted it pretty well with behavioral health, but now we're really starting to try to get it going with our primary care services. So some of the chronic problems that we were able to identify that could have a telehealth visit were patients who are, for example, on antihypertensive medications. So we are able to do new patients also. So we actually had a visit with a new patient who she really just wanted to get established, and she needed a refill on her blood pressure medicine. So I was able to get all of that done for her, do a really great history over the Zoom, which is the platform that we're using, and also have her give me her objective information. So she was able to give me a log of the values of her blood pressure readings. And so with that, I was able to adjust her medication accordingly. And that turned out to be a really great visit because I was able to really talk with her about her past history and get a lot more information than I probably would have when she was sitting, because I'd be needing to do her physical exam and all of these other components that we normally do. The next visit that we've been testing out are diabetes visits, particularly for those patients who are better with checking their blood sugars and giving us a log of their numbers, and we're able to adjust their medications accordingly. Of course, we can't get their A1C results, but we can at least get a good picture of what their random and fasting blood sugars are. We have some patients also that have home INR machines, so we've been able to do some Coumadin management with them over the phone and also with face-to-face Zoom. And then also we had a patient that wanted to discuss treatment options for IBS. So that was a conversation that was had discussing previous medications and what medications we can transition to. And it really was a consultation type of visit. So we were able to do that. Some other visits that we are looking at or have done also include follow-up on medications. So if a patient has been started on a medication, we can do a Zoom and find out how they're doing on that medication, if they're having any side effects and things like that. Contraception management, starting contraception, or also a discussion about what types are available for the patient. We also have done a couple of acute problems listed here. We had somebody with cellulitis, and I actually have a picture of that person. And just to give an example of what is a good way to use the telemedicine, we had a patient with a urinary tract infection, conjunctivitis, and then we had some patients that needed some paperwork completed. So we were able to do that by Zoom also, and then lab review. So those are all some examples of patients that we were able to impact with telehealth. And this is the example of the patient with the cellulitis. So you can see one arm and then the other arm. So the picture, I was able to view what the problem was and determine, whether that person needed more than just an oral antibiotic or not. And so they were able to get treated. So I thought that was a really good example of how we're trying to utilize telehealth. Okay. So then, according to our billing and coding is a little bit different because we are a rural health clinic. So our billing is guided by, of course, CMS. However, we also fall under the category of a rural health clinic. So there's some services that are not typically able to be billed in a rural health clinic. And additionally, we get what is called an all-inclusive rate. So we, no matter how many different things we do, like in a fee-for-service model, we don't get a reimbursement for every item that we do. We get a lump sum reimbursement, and that is determined by our location and by CMS. So what we've been doing, we have been told from different organizations, mostly we are connected with the National Association for Rural Health Clinics, and they have been providing us with ongoing information on different codes that we're supposed to use. So with our Zoom visits, we are using our E&M codes with a 95 modifier, and the rate is set at $92, but we're not really sure if we're going to get that yet. We're waiting on some reimbursement to see if that is going to happen. And that is only with the face-to-face video, with the video. And then after June of 30th of 2020, we are supposed to use a G2025 code for our telehealth services. So that might change by then. Next slide. Then we've also been using some other codes as well. We have been doing some virtual communications with patient portal and also with phone. So we're using the G0071 reimbursement code and also the 99421 through 99423, depending on the time frame, trying to see if those codes are also reimbursable. And those are not face-to-face, those are all virtual communication codes that we're doing. So in order to make this a little bit smoother of a process, our front office is not only identifying the patient, but getting consent from the patients and then documenting that in the chart with a quick text stating that the patient is consenting to any and all of the virtual communication and Zoom meetings and whatnot. So next slide. I think that might be the last one. Can you guys hear me?
Yes, we can hear you, Denise.
Okay. I think so. Go ahead.
Is there another slide?
I don't know.
Okay. Well, Denise, thank you. We really
You're welcome.
appreciate your perspective from a rural and nurse-managed health center. I love visiting you guys. I love that you got your new building in there, that photo. Congratulations. And just thank you for all of the work that you and your team are doing there. So thank you.
Thanks.
So next we're going to turn over to our third polling question. And for this question, is your health center patient population utilizing at-home monitoring devices? So it's yes, it ingests directly into our EMR, no, or yes, but patient self-report the information to care team. So on the next slide, you'll be able to answer the question of, is your health center patient population utilizing at-home monitoring services? So first response would be yes, it ingests directly into our EMR, no, or yes, but patients self-report information to the care team. Then the care team would put that information into the medical record manually. So let's give it just a moment and we'll get responses. And this is what is currently being done. Ideally, we'd like it a little bit different than what I think these answers might be. So Stephanie, why don't we close the poll and we'll see the percent changes here. There we go. So it looks like yes, 5% ingest directly into the EMR. Congratulations there. No, at 32%. And the largest percentage here at yes, but patients self-report the information to the care team and then is manually entered into the patient's electronic medical record. So thank you very much for that third quick poll question. And now we're going to hear from another one of our colleagues, and Dr. Jennifer Vargas is from Alivio Medical Center in Chicago. So Jennifer, are you with us?
Can you hear me?
Yes, we can.
Hi, everyone, and thank you for inviting me to share Alivio's practices with everyone. So just to give you a little background on Alivio, we are a federally qualified health center, primarily in the Chicagoland area. We serve the uninsured, underinsured, and undocumented members of the Latino community. We have six sites. 3 of our sites are primary sites and 3 school-based sites. Unfortunately, our school-based health centers are currently not being utilized for obvious reasons. We tend to open one school twice a week for well child visits, but otherwise we're primarily using just our 3 primary sites. We have a total of 35 providers, 18 primary care providers, 1 OB, 1 urologist, 9 certified nurse midwives, 6 behavioral health providers, and 1 dentist. So as Archer Family Health Center mentioned, we also, because we're governed by we are federally qualified health center, we weren't using telehealth until this pandemic. So we went live with telemedicine about 3.5 weeks ago on March 30th. We started off using just telephone service until we implemented the Doxy.me, which has actually been very helpful. We are currently providing telehealth services on all our practices except for dentistry. We just haven't figured out how to use telemedicine in dentistry yet. But after today's talk, I think we will be able to implement it soon. So in primary care, we've utilized, we had to determine what is considered an appropriate telemedicine appointment. So we had guidelines to provide our schedulers, our call center, and our providers. So listed, we have diabetes or any chronic illness follow-up, annual visits, well child visits that did not require any vaccines, basically any child over the age of 2, except for the 4-year-old well child, because obviously that is the time that the 4-year-olds need vaccines. Any older person over the age of 60, all our behavioral health appointments transitioned over to telemedicine. Our ER follow-ups were telemedicine appointments, and any of our patients that had already been tested and were positive of COVID-19 were infected with the virus, and they needed to have a letter to go back to work. We would implement a telemedicine appointment within 7 days of their diagnosis, and then 14 days later for follow-up. And then our urology visits were telemedicine. Next slide. Our OB department also, we implemented using ACOG guidelines of what would be considered appropriate telemedicine appointments. So any of our visits prior to 12 weeks of gestational age, so our new OB visits are just for pregnancy education. We did the 15 to 20 week visits, which is generally our genetic testing and our 1-hour glucola test. Our 24-week visits being our, again, just checking in, reviewing any danger signs, any plans for labs and visits. Our 30 to 34-week visits, which will continue the birth planning, again, signs of warning signs and labor signs. And then our 37-week visit was also a telemedicine visit. We implemented 2 weeks post-delivery visits, would be like our wound checks, our depression, breastfeeding issues. We also implemented any lab results, follow-ups, PAP, POPO results, any infertility consults, birth control consults, and then follow-up on IUD placements, implant insertions, and any startups on birth control. Next slide. So these are some of the coding that we've used in, we're obviously still learning. We're primarily in primary care using the E&M code with a GT modifier. In OB, we're also using the E&M code with a GT modifier in behavioral health as well. Dentistry, like I said earlier, we're still working on figuring out how to implement telemedicine in dentistry. So the coding part is still pending. Next slide. So with the start of telemedicine, it has been somewhat challenging for us, not only for our patients, but also for our providers. It's a new way of practicing medicine. Providers we're normally hands-on. So telemedicine has definitely changed the way we practice medicine. Providers had to learn a new way to document, new ways to examine, and a new way to code. So coding and appropriate documentation, I think, has been the most challenging for the providers. In order to help that, we implemented quick text. Quick text have helped us. It's pretty much stating the reason why we're doing a telemedicine appointment, whether it's by video or by phone. We also, in our quick text, implement that we've obtained a verbal consent. And then if we're not able to do a video, why are we having to do a phone visit? In our visits, we attempt to document the vitals, that we ask our patients to go ahead and check their vitals, their temperature, their blood pressure if they have a blood pressure monitor, their glucose if they have a glucometer. We ask them to check their pulse. And then in our physical exam, we're obviously able to visualize a lot of the exam, which is actually something that we didn't realize how well we can examine someone just by looking. So we document the general appearance of the person, their eye exam, their neck exam, their respiratory effort. We evaluate their skin. We can look at their lower extremities and evaluate for edema. And then obviously for our diabetics, we evaluate their feet. We look for ulcers. We could also obviously look for edema. And then we document on mood and affect of the patient. For our assessment and plan, we pretty much document the same as we would do on a patient that would come in. All we have to do different is document the time spent on the visit, especially on the counseling. On the patient's end, we have found several other challenges. Our patients are, as I mentioned, a lot of them have lack of knowledge of technology. A lot of our patients are elderly. They don't have anyone else in their household, so they don't know how to access, how to log in. A lot of our patients may not have good Wi-Fi or internet service. And then we've also experienced some audio issues. So to combat these challenges, when we implemented telemedicine and developed the appropriate criteria for what is considered an appropriate telemedicine visit, our call center, our schedulers went ahead and called all our patients, and they informed them of this new switch to telemedicine. They provided them the option of switching over to a video conference or to continue to coming into the clinic. If they opted to come into clinic, we had established days and times of appointments, so that way they would not have any risk of exposure to the virus. We also implemented screenings at the door, temperature screenings, and we provided masks to all our patients who still needed to come into the clinic. But for those patients who decided to do telemedicine, during that initial call, we would inform them of what the process would be. We tried to talk them through the whole, what they would encounter, and trying to discuss how they're going to get an invitation from the provider, how to click the link, how to submit their name, and then once that appointment was established, and the day of the visit, 30 minutes prior to the patient's appointment, they receive another call from the schedulers, our front desk reception, and they go ahead and pre-register the patient. And again, they ask the patient if they have any questions on how to log in. They walk through the process with them again, and they inform them that what they're going to be receiving on their phone. Obviously, the most important thing is to make sure we have an appropriate or the correct mobile number and not their home number. And then when the provider is ready to start the visit, and they send the invitation to log in. If we haven't heard anything within 5 minutes, the provider goes ahead and calls the patient again and asks them what issues they're encountering, and they try to walk it through again another time. So we try to do the best we can to help our patients establish this video conference, although sometimes it's still not possible. If it's not possible, we just go ahead and convert it to a phone visit and continue the visit on the phone. So despite all of these challenges, we have to date had 928 primary care visits via telehealth, 248 behavioral health visits, and 138 OB/GYN visits. So every day we're learning how to improve our process. We're learning how to provide, trying to provide quality healthcare in a new way. And I appreciate the time that you gave me to provide some information and at the same time learned from other clinics. So thank you very much.
Great, and thank you very much, Dr. Vargas. I really appreciate that. I really appreciate what Alivio is doing for your patient population. And it really, part of this webinar series is that we learn from each other. I learned from your presentation here today on the physical exam, definitely. And I'm sure it's so great to hear that you learn from others about the dental health. So thank you. That's what these webinars are all about. So next, let's turn it over to our colleagues on the national level. And here we've invited Dr. Julia Skapik, Medical Director of Informatics from the National Association of Community Health Centers. So Julia, are you with us?
I am. Can you hear me?
Yes, perfectly.
Excellent. Well, let's get going. I'll try not to take up too much time so everyone can get back to the important work they're doing. Many of you are familiar with NAC's mission, and our mission is basically to support all of you in promoting efficient and providing high quality, comprehensive health care that's patient-centered and culturally competent. And I just want to echo the other speakers and thank all of you for the incredibly important work that you're doing on the front lines, maintaining the health of our nation's safety net while also responding to an emerging and sudden public health crisis. So I put this slide here just to remind us that, the quadruple aim and some of the principles that we always apply to our regular sort of healthcare processes should similarly be applied as we're making big changes. And we want to think about, as we're making changes to the way that we work, understanding the bottom line and what provides us with more or less return on investment, incorporating metrics or measures into the process that we're changing so that we can understand what those impacts are. And then, of course, you have absolutely no choice here, but to do that rapid cycle process improvement so as things change, which they are very rapidly, that we can adjust and continue to get better and better. The 4 bullets on the bottom here are techniques that many of you use and NAC sometimes uses to help ensure that we're doing these first 3 things in a way that's adding to the experience of the care team, the patient, and the outcomes we want to see. Next slide. So it's a frustrating thing at the national level that funding for emergency preparedness is almost always entirely reactive. So no one has come to you and offered you support for emergency preparedness sort of in the year prior to the COVID outbreak. But of course, the minute it shows up, people try to throw money at it. And one thing that NAC feels is important is if we have the opportunity to get these funding resources, or even if we don't and are forced to make changes, we can still use that as opportunities to understand sort of where our operational limitations are and try to be creative and work in ways that provide infrastructure for the future and allow us to respond better in future crises. Next slide. So this is actually a standard sort of slide that I use to list some complaints and problems with typical EHRs, but I'll say that focusing on some of these is really important in a crisis, because even less so can we afford waste or steps in the wrong direction. So focusing especially on things like missing data, and things that interrupt workflow or don't add any value to the clinical virtual care approach. You want to sort of keep a close eye out for those, because we don't have additional time and energy to sort of spare during this this important time. Next slide. So unfortunately, even though it seems like things are sort of, the train is moving rapidly down the track, it is important to stop and think about strategic approaches to implementing these kinds of solutions that we've talked about today. And I think it's very obvious that many of you are being very thoughtful about how you go about changing the way that you work and responding to this crisis. I encourage people to sort of sit down and think about, is there a way that we can align multiple use cases or requirements that are upon us right now so that we can be more efficient? When we think about aligning those use cases or those activities or care pathways, we also want to think about what is the data that's needed to support that work, so that that data aligns as well, and we are able to analyze that data and make good decisions and improvements. Next slide. So I use this slide because I see still, unfortunately, many data efforts, and this is common at the national level, that people say, oh, you know, it would be good to measure, let's measure this, that, and the other, but they don't say, what am I going to do with that information? How would that information change what I do? And sort of do that kind of cost versus benefit analysis, and make sure that at the outset the things we measure really do help us to meaningfully change those activities in a way that improves what we're doing. Oftentimes we make the assumption that just gathering some kind of data will be useful for a purpose. It turns out not to be quite exactly what we needed. And so take your blindfold off and sort of boldly head up the mountain. COVID-19 has already changed the health IT regulatory landscape. Now, there were a number of sort of major shifts that were happening in the industry, but there's definitely been rapid acceleration of some of these policies, and telehealth is a perfect example. It remains to be seen exactly what the lasting effect of these changes will be, but I can tell you for sure that NAC, and many thanks to our policy and TNTA teams who have been working very diligently in advocating for health centers to get better telehealth reimbursement and to try and remove some of the red tape around some of these, some of the regulatory issues. Next slide. So NAC has partnered with all of these organizations here, including the CDC. If I have time, I'll mention that we're actually working on some electronic solutions work in the primary care setting with them, but as you know, there's a case report form, and some of you may be subject to having to gather data for your public health agencies. So there are actually a number of resources at this link that may help you with understanding requirements around reporting. Many of you may have responded to the HRSA Bureau Primary Care Survey. We are working with them to improve and make that very actionable, as well as the PCA survey. And you know that we continue to work to advocate for changes to telehealth reimbursement, which is at the federal and state level. Next slide. I'll just call the CDC website out to you, because there are actually some guidelines here that you could use for telehealth phone screening if you want to determine who should and should not come into the clinic. And actually a colleague at CDC pointed this specific resource out to me, so I just wanted to throw that up here. I also wanted to call out the changes under the HIPAA. As you know, HIPAA is the Health Insurance Portability and Accountability Statute, which normally talks about privacy. As you know, telehealth sort of loosens the requirements that previously were on systems that perform telehealth and allow you to use things like Zoom. I think it's important and useful to have multiple ways of being able to reach out to patients and respond to their needs. There are on the OCR, HHS Office for Civil Rights website, a notice of enforcement discretion. Basically, they say you can use things that previously weren't allowed. They give a lot of examples like FaceTime and Google Hangouts. And then also text-based applications that you can use for people who have issues with video access. You can't use things like Facebook Live, but some of these reductions in the level of enforcement will be helpful for you as you're moving into a sort of rapid implementation of telehealth, or as you need backup modes for your providers. But planning for a rapidly implemented telehealth success, as you know, there are a lot of different components. We heard about a lot of these actually very effectively from the other speakers. These are just some highlights that I think are really valuable. Making sure that you're documenting the workflow for your providers and team members so they understand who's supposed to do what when in the telehealth process. This is also useful, right, as some of your care team members may get sick and you may need to bring new people on or repurpose staff for other activities. A telehealth documentation cheat sheet can be very helpful. Many clinicians are used to having a very sort of set way that they do their daily activities, and this major disruption can sometimes create opportunity for patient safety mistakes or documentation mistakes that would limit your ability to bill at the right level. So including that documentation around the clinical visit, also support for billing. And we know that these billing requirements are changing frequently. So I would expect that you could do little videos and to provide updates as well as sort of static documentation. Helping people to understand when they can use phone versus video is important, and we know that that does change, as I said. When you can, add clinical decision support to your EHR, like an order set or a template or a list of billing codes. We encourage you to do that to make it easier on, again, to implement a new workflow, to reduce variability, to make sure you're getting paid at the maximum level. And consider capturing new data elements. So many telehealth platforms will record how long the visit is. You may want to start tracking what kind of visits take what kind of time. Are you able to upcode for some of those? Tracking how many virtual touch points are being made to an individual patient. Could you streamline some of those, or are they all adding value? Looking at places to capture remote vitals and monitoring, so you understand the difference between a patient-reported value maybe and a clinic value over time. Next slide. I just want to emphasize the importance of testing, even if that's having one or two people just in a fake encounter go through the system. I remember one time in an EHR I used, they changed the discharge workflow, and what used to be a 2-page discharge document was a 26-page document. And the worst part was there were no page numbers. And I said, one test could have avoided this problem. So just remember to, as you're making these changes, to make sure that you're doing testing. And having backup methods is important whenever you can. I suggest everyone identify a method for users to report issues and suggest improvements. That's often where some of the best ideas come from. Next slide. Patient-facing virtual management can be helpful. This is just an example of a solution that's targeted actually towards pregnant patients who are concerned about COVID-19 related visits. I would encourage you to consider methods where you can use the phone or virtual triage visits to evaluate and test technology at the patient side, encouraging reminders to patients like have your medications and your devices and write down your questions next to you when you're at your visit so you can you don't forget to sort of bring up important things to the patient. Encourage people to use the patient portal, can help you to have some of that information document better. Next slide. There are symptom trackers out there. They can be helpful if you have tested them and moved them into your workflow. I don't endorse this one in any way. It's just an example. Next slide. But keep in mind that A patient-facing application may or may not have the same level of privacy and security protections that we rely on in sort of the EHR and health IT setting. Next slide. So public health emergencies can be opportunities for the greater good. We've been hearing patients who never wanted to get vaccinated before are calling the clinic asking for vaccines. Telehealth use can actually help to address health disparities. Some big technology firms are improving the interoperability of their content. Next slide. And rapid expansion for other kinds of virtual services is probably helpful, as well as sort of the belief that the general public has in scientific evidence and sort of trust in their health providers. Next slide. So I'll just say that NAC is doing a number of things on COVID-19. I don't want to get into the details because I know we're up against the end of time. So if you can just flip through a couple slides, Stephanie, maybe like a few seconds per slide. We're continuing to use human-centered design. Keep going. At NAC, we're building a data dictionary around COVID-19. Keep going. That includes using some existing content that's available in open source standards. Next slide. And working on creating sort of registry functions so that we could do things like advocate for health centers and help to address supply chain shortages. Next slide. And then tools like risk calculators that would help all of you to streamline your work. Next slide. Thank you again for everything that you're doing. I will ask Stephanie to share a resource slide that NAC has put together that has resources from hers. Oh, there it is. All over sort of NAC and NAC's partners that may be helpful to you during COVID-19. So thank you very much for having me today. And again, thanks to all of you for all the excellent work you're doing. If you would like to reach out to me, either with issues that you're having around telehealth or success stories, I will be more than happy to send those to the right people at NAC, assuming I am not the right one. But thank you. We love to hear about all the amazing stuff that you're doing.
Great. Thank you very, very much, Julia, and thank NAC, and thank all the hard work that you're doing on behalf of all of the community health centers. So to close today's webinar session, I want to thank all of our speakers so much for joining in today's webinar. Hopefully we'll be able to have these webinars every Wednesday. So stay tuned for next Wednesday's webinar. And here, as you can see, as we close out today's webinar series, the one word that describes what you appreciate most about your health center population. This is our word cloud for today. So on behalf of Health Choice Network and Alliance Chicago, my name is Tim Long, and we will be talking with you next week for session 7 for COVID-19, preparing our communities. Thank you, thank you, thank you for all the work that you do. Have a great day.